broadly, how can we approach the skin and health and disease in a more holistic way? That's very much what drives me. So I'm always looking outside of the box, but also the inside the box. And of course, inside the box, there's a lot going on. I wanted to talk about a couple of things in particular, and then we'll definitely have some time for question and answers at the end. But I wanted to talk a little bit about, there are a few ways of thinking about the severity of the skin. And you will hear this come up a lot because people, when they're going to get certain medicines, many times in order for that medication to be covered, there actually has to be a level of disease severity that is met. So let's say, okay, this is only for moderate disease, or this is only for severe disease. And if you don't have that, if the doctor or clinician who's seeing the patient, if they don't put that down in the chart, then the insurance company might say, no, we're not going to cover that because you're an inappropriate patient. So it's kind of interesting to think about how we approach this problem. And it turns out there are a bunch of different scales that are out there. These different, they call them assessment tools that we can use. One of the most common ones is on the left of the screen. It's called the EASY score, and that stands for Eczema Area and Severity Index. And it's kind of fascinating because it looks at the body, it splits it up into kind of quadrants, and then you sort of assign a score to each different aspect. The redness, the scaling, kind of goes through all these different things. And then you get like a number between 0 and 72. It's very good. It's used in a lot of studies, but it's really difficult to do on your own. It's really even hard for me, like clinically, to do it. It takes a while. Like you're doing math and you have to write stuff down. So we pretty much only use it in a trial. Like if I'm doing a clinical trial for a medicine or a treatment. And the other problem with it is that it is extremely focused on just what we're seeing at that moment. And we know that eczema is something that goes up and down. So on any given day, it could look substantially better or worse than it did yesterday. And I think that is a huge limitation of that tool. It's still a good tool, but it really limits us. It also doesn't capture things like quality of life or how it's affecting sleep. And so I think it has a big, big limitation. The same goes for the next one on this list. You can see IGA, that stands for Investigator Global Assessment. That's one we do on every single patient. It's also been studied a lot. It's been validated to be helpful, but it has the same kind of limitations. There, it's literally just 5 points. You're clear, almost clear, mild, moderate, or severe. So it's 0, 1, 2, 3, or 4, 5 points total. And that's really all you have. And again, it's the same limitation. It misses out on all sorts of different aspects of the disease. It's very temporally locked. So I've had patients say, I know I look good today, but the last 3 months have been terrible, and I say, of course I understand. It's just difficult because if I put down today they're mild, that could literally affect their ability to get a medication covered. And there are, of course, other different tools out there. But the one I wanted to spend a couple of minutes on was one that I think has been transformative, has really kind of changed the game. And that's this one called the Atopic Dermatitis Control Tool, or ADCT. And this is really interesting because it is a little bit broader. First of all, it's all patient-reported outcomes, meaning the doctor or clinician doesn't do anything. The patient answers it themselves. There's 6 questions. And what I love about it is it takes less than a minute to do. So everybody can do it. You can, of course, do it at the time of the visit, or, literally, you could just have the patient do it themselves. And reason I'm presenting this today is I really would encourage everybody to do it themselves and try it. Or if you have a patient, child at home or a family member at home, feel free to have them run through it. And this is what it looks like. These are the 6 questions. You can see them here. And it's really straightforward. And each one, you'll notice, it starts with the question about the time. It helps us address that aspect of time. So each one begins with over the last week. And that's really neat because, again, it helps break the spell of saying, okay, we're only asking about this exact moment. It really gives us a sense of over the last week. And then you can see the first question is, how would you rate your eczema-related symptoms? So 0, 1, 2, 3, or 4 points. And you can see it's none, mild, moderate, severe, very severe. And then the next one is over the last week, how many days did you have intense episodes of itching because of your eczema? It then asks about the trouble falling asleep or staying asleep. It also asks about how bothered have you been by your eczema. It also asks about affecting your daily activities. And then finally, that last question is how much did it affect your mood or emotions? And this is my favorite thing. So I feel very strongly that if we can get patients to do this, what this is asking, though, is something different. It's not asking about the severity, because to me, that's much less important than what this is asking. It's asking about control. Are you under control? Because the truth is, some patients look really, really severe when I meet them, but I can get them under control pretty quickly. Other patients look not that bad, but I can't seem to get them under control. I'm throwing everything but the kitchen sink. And that's why I think this is a much more important question, something that we can have families and patients do, and then we could bring it to our visit and say, hey, listen, I know, you're doing some stuff for me, or we've been trying this, but I'm really not where I need to be. Because when you tally these up, your goal is to be below a 7, so 7 points or lower. And here, if we're not, what we'll find is that many of my patients start the visit out by saying, I'm like, how are you? How have you been? They say, I'm pretty good. I think things are okay. Then we do this. And then sometimes they'll start crying and say, oh my goodness, I'm not so good. They have a 14 or an 18, really high scores. And you're like, okay, you're not under good control. You're not where we need you to be. And other times, a patient might look a little bit flared up that day, but then when we do this, they still get like a 5. And I say, okay, so maybe this is just a little tiny blip. This is a blip, but you're doing pretty well overall. So over the past week, you've actually been really in good shape. And that can be helpful too. Of course, it can change week by week, but it's such a nice way to look at this. And I find that I'm doing this with almost all of my patients now, or trying to. And I try to put that in as we can track it. So I definitely encourage everybody to check it out. It is totally free. It is not branded in any way. It was developed by one of the drug companies, but it's open for use by anybody, and on the site, there's no branding at all. They used it in some of their trials, which was really neat. And it's on the web at AD Control Tool, so adcontroltool.com. And you can search for it. It's fantastic. And you can do it as often as you like. You can check in once a week or every couple of weeks and kind of see. And I highly recommend that you print it out and you bring it to your visit. I think that's such a powerful way to change the discussion or move things forward, especially if you're feeling stuck. If somebody kind of dismisses and says, gosh, I think you're doing fine. I don't think we need to do anything more. Here's some more triamcinolone. Good luck. You can say, doc, I'm not doing great. I'm not under control where I want to be. And I think that's a powerful tool in our toolbox, because I know, my other hat, I'm a board member for the National Eczema Association. So many of our patients feel unheard. So many of our patients feel that they're not getting the kind of treatment that they want or the level of improvement that they want. They feel dismissed sometimes. And it's hard because, there's an awful lot of people who treat skin conditions. In some parts of the world, it's mostly general practitioners who do it. And some are great, some maybe not so great. But even in specialized practitioners, even in dermatology providers, we definitely have a range. There are some who are really devoted and trying their best and creative, others who it's not their interest. So they just want those patients out of the office. Maybe they're more focused on skin cancer, or they're more focused on procedural things, surgeries and things like that, or cosmetics and lasers. So I hear this kind of complaint all the time that people feel unheard. And I think this is an empowering tool. So I'd love to point that out, and I highly recommend everybody check that out. Now, this kind of bridges into, what do we do with that information? How do we think about that? And one of the things that's really important to me is this idea of shared decision making. So if somebody says, hey, I'm not where I need to be, well, that means we probably should do something about it, right? What can we do about it? And we have to figure out our next steps. But to do that, especially as we've used, the basic things, everybody should be taking gentle care of their skin, avoiding things that we know are triggering up a flare. And of course, people want to have a good education and a foundation on what to expect and what the causes are and why it's happening to them. And for some people, that's enough. For mild cases, just avoiding things that are irritating, changing things about their house, maybe using a gentle moisturizer, they're fine. Those patients are really lucky. They're mild enough. They don't need any major intervention. Of course, lucky patients find a food or foods that drive it, and then they're very happy about that. They're like, oh, I found this food and I avoided it. I'm perfect. I don't get to meet those patients though, right? People only come see me when they generally have tried all of the above plus 25 other things, and they're really desperate and they're really frustrated. And they often feel like they've been told all these different things, and they sort of haven't panned out. Many patients see me when they're a little bit older and they say, everyone kept saying I'd grow out of this. Why haven't I grown out of this? Other patients have tried crazy diets. They said, everyone told me it was gluten and dairy. So I was off gluten and dairy for 2 years and I was still miserable, and it didn't help. Why didn't it help? I thought that was the secret, Well, for them, it wasn't, unfortunately. Other people say, it was a certain kind of moisturizer or a magical product or whatever, everything, different herbs or supplements or you name it. So I've seen it all. And again, for every one of those things I've mentioned, there are lucky patients for whom that made a difference. But That's not who I see. So for the patients I see, I really try to talk about what is our next step. And we do this little process called shared decision making, where we kind of talk about the different options. And it's not just medicine, right? Sometimes it could be things like going to the hydrotherapy center someplace. And I was telling Jennifer before we started, I have a patient of mine who's really severe, and we were able to get her a slot to go to France, the south of France, Avesnes, France, and actually spend 3 weeks getting special therapy with the healing waters there. And it's pretty amazing. It's kind of an amazing experience, a life-changing experience. And actually in France, that's actually part of their healthcare system. So if you have eczema or psoriasis or a whole bunch of other skin conditions, burns, things like that, you actually can get as part of your healthcare, you just get 3 weeks at the center every year. And so when we were there were patients who were like, this is my 4th year. This is my 14th year. They've been doing it their whole lives. And it's amazing. They sort of get a 3-week spa is a funny word, because I think in our part of the world, spa kind of has a connotation that everybody's wearing luxurious robes and, sipping on cocktails. It's not that kind of a spa. It feels more of like a hospital treatment center, but you really are getting these natural mineral waters, which is pretty neat. So when we do this, we kind of make this decision. And I like to think about each treatment, again, medicine or not, I like to break it down into efficacy, accessibility, and that includes things like cost and route and time it takes, safety and tolerability. And then I've sort of added one more. So I've changed it from east as my mnemonic to estar, because and of course in Spanish estar means to be, or we can anglicize it and call it estar, right? So the idea here is efficacy, safety, tolerability, accessibility, and remission, because increasingly we're finding that some of the newer treatments may actually put patients into a state of remission, and that is super duper duper exciting. That meaning you could potentially stop the medicine after a certain period and the patients would stay pretty clear. And I see that all the time. Now, I can't promise that yet. I can't wait until the day I can promise it, but I really do find that if we get people in a better place, we break the cycle of itch and scratch and bad sleep and all this kind of stuff. What we find is that we generally can start easing up. We can remove treatments, and that's an incredibly exciting point. And for many of my patients, in fact, I wrote a paper about it a few years ago. I had patients who were on a biologic medicine, that one of the shots for about a year, and for varying reasons, they had to come off of it. And of that entire cohort who came off of it, not a single one of them had a rebound flare up. Not a single one of them went back to where they were before they started. So that was kind of neat. Now, they weren't cured. That's a different concept. I wish we had a cure, but they were better for a long time, even after the medicine. And that's something. That's step one, right? That means something. So I kind of think about these things and we talk about it. What about topical steroids? What about non-steroidal agents? What about these biologic shots? What about these new pills? What about light therapy? What about hydrotherapy at a center? What about cold plasma? What about red light therapy, right? There's so many things we can do and so many things patients bring up. What about traditional Chinese medicine, herbs? What about some of the natural treatments, natural oils? What about coconut, sunflower, all these different things. So I'm very interested in all of those things, and we get to talk about them. And of course, almost none of my patients is on only one thing, right? We often are making a cocktail of different approaches. So different types of cleansers and creams and moisturizers and oils and supplements, all these things together. And we kind of have to do something like this for each one to kind of talk about what can you expect and what are the pluses and minuses. Because I will tell you this, and I think we all know this fundamentally. The common sense is that anybody who tells you something is perfectly safe, has no side effects, they're either full of baloney or they really don't know, right? Because if it does something, then it can do something bad, right? Even the gentlest thing, even water, gift of life, right? We love water. We're made of water. If you drink too much water, you will die. Potomania can kill people. I mean, literally, you can wash out the gradient in your kidney and die. It sounds crazy, right? But you really can, just drinking too much water. Now, it's a crazy amount of water, but it really happens. In fact, there was a couple of years ago, there was a radio program that had a water drinking contest. It seems so innocent, right? And somebody drank so much water, they actually died doing it. So we have to keep this in mind. Anybody who tells you there's no side effects either doesn't know what they're talking about or is outright lying. And that's important because every treatment does. Now, we know there are a lot of conventional things that we've used for a long time for eczema. Of course, our topical steroids have been around since the 1950s, and they're important because they are very, very effective. They're very reliable. Almost everybody who uses them does get better, and that's interesting. And they're pretty safe when they're used correctly, right? I really think they can be, but a lot of times they're used not so correctly or in an inappropriate way, and we see a lot of potential side effects and real side effects from them. And then we have things like our calcineurin inhibitors, that's tacrolimus and pimecrolimus, and we have kind of more recently crisaborole, which is a topical phosphodiesterase 4 inhibitor. So we've had some newer treatments. And how do they fit together? Well, there are some really nice guidelines that have helped us put things together in kind of this staircase function. We call this like a therapeutic ladder or a therapeutic staircase. We kind of start at the basics, and you can see the bottom is what we talked about: good education, moisturizers, gentle bathing, avoiding relevant allergens, right? Like really minimal. We don't want to do stuff unless we have to. And we love when patients get better with just that. Like that's the dream. If you don't have to use anything, right? I don't like being a pill pusher. I'm not trying to put people on medicine. In fact, my joke to my patients always is, if I do my job well, I will literally not be useful to you anymore. I want to make it so you do not need me, right? My dream is that you say, oh, that guy was great. He really helped me when I needed him back then. I don't need him anymore. I want to make myself completely obsolete. That's how I know I'm doing a good job. And we start, of course, at the baseline, then we go up to our basic topical therapies, then we have some more intense therapies that we can use. And then we really, if we're still not doing well, or we're not doing it safely, and that's what I see a lot. Patients say, doc, if I use my topical steroid, maybe they're using their triamcinolone, they got a big tub, I'm burning through this, every week or two, I'm using a whole tub, a whole pound, or 454 grams. And I say, that's not safe. Like that's not good. You can't keep doing that. We're going to get into trouble, or potentially get into trouble. Are there people who have dodged the bullet? Yeah. I mean, there are lucky people that have abused things. I mean, we know this with drugs or anything, crazy driving, drinking and driving. There are people who it hasn't caught up with them yet. Maybe it never will, but that's not a way to live, right? We don't want to be tempting fate over and over. So when we see this, I say, listen, maybe you haven't had a side effect yet, but it's not safe. So we need to think out of the box. And that's where we can kind of step out of the box, and we can talk about some of our systemic approaches or our non-steroidal approaches. And I was lucky enough to be part of a really neat group called the Joint Task Force for Allergy. This is the two big allergy groups in the US and Canada. And actually the lead author of this is Canadian allergist. He's a wonderful guy, Derek Chu. And I'm on this paper where we made some new guidelines, and it was really exciting to look at all the evidence. And we actually brought patients with us too on the journey, because their voice had a big impact. And in fact, it's caused kind of a stir, because our our guidelines are a little bit different than the American Academy of Dermatology's guidelines, because the patient voice changed it a little bit. I'm actually proud of it. The AAD, the dermatologists, are a little mad about it. In fact, and I sit on that committee as well. So I'm like writing a letter to myself, but tried to allay their concerns, but they still wrote a letter, and there's some discussion about it. I think it's healthy discussion personally, but one of the things that came up was just the potential safety of some of these things. And I think a lot of our patients really do worry a little bit more about that. So looking at our topical therapies, we have our moisturizers. Here we're talking about prescription moisturizers, which we don't think are generally worth it. So we say conditionally against. There might be some situations where you can write a prescription for some of these very fancy schmancy kind of prescription ones, but typically we don't need them. We have our topical steroids. They're really good. We still have to be careful with them, but they definitely are helpful. We have our calcineurin inhibitors. That's the tacrolimus and pimecrolimus. Those are really good. We have our phosphodiesterase 4 inhibitor. Right now, the one we have is crisaborole. Yeah, pretty good, right? It can help. It has some setbacks, but conditional in favor. And then we have one of our newest treatments, which is topical ruxolitinib, which is a JAK inhibitor. And our conclusion here was conditional against. Now, on the American Academy of Derm, it's a strong, 4. But I think it's still a good medicine. I use it a lot, but I think the issue here was that some of the patients were a little bit nervous about it, because it has one of those kind of scary boxed warnings that talks about potential risk for cancer and blood clots and all these kinds of things. I think it can be kind of scary. And then it goes on to talk about a couple of other things, but I want to zoom ahead a little bit. And I want to talk about, this is the American Academy of Dermatology's guideline, just showing us very similar overall. And they have a very, very similar kind of conclusion as we did in the allergy group. So I think that's nice to see there is harmonization even across different groups looking at the same data, but there are some important differences. Now we'll kind of shift gears to the other part, which is really what brings us to the non-steroidal. And a lot of my patients that I meet, they start the visit with saying, Dr. Leo, I'm excited to see you, but first things first, I want no steroids. Do not give me steroids. I'm not going to use them. And that's how a lot of my visits begin. Now, so many begin that way that I'm not surprised at all. But I will say when I was younger, it was kind of shocking, because of course we use a lot of steroids for eczema. It's one of our, as you saw, it's the top line for both guidelines is to start with them. But I take that really seriously. So I put together a paper, it just got published a few months ago, all about a non-steroidal therapeutic ladder. So kind of an approach we can think about completely avoiding steroids. And again, on the base, you can see the foundation of this again is good education, avoiding known triggers, gentle bathing, good moisturization. So all the simple, safe stuff, right? If that's enough, you don't have to go any higher. But then I kind of rank them, and this, I will admit, this is extremely it's very much subjective, right? So I put like a disclaimer. I'm like, this is our interpretation of thinking about it, and we totally admit there's not any specific guideline that says one is more dangerous than the other, but we kind of rank them into sort of real and perceived safety. So the phosphodiesterase 4 inhibitors seem really, really mild. They're sort of gentle anti-inflammatory. They're approved in the United States down to 3 months of age, so they're pretty mild. We feel like, but the trade-off is, of course, they're maybe not that powerful. Then we have our calcineurin inhibitors, and then we have our JAK inhibitor. Then we have kind of, if you look on the right side rather, where the maintenance. So I have it as a flare up and a maintenance concept. The maintenance, then we get into some of our bigger agents like light therapy. And then we have our biologics, our oral JAK inhibitors. That's the abrocitinib. And of course, we have the three in the other parts of the world, baricitinib as well. But in the US, we only have the two. But we then have our final piece on top, which would be the kind of historic systemic immunosuppressants. And that would be things like cyclosporin and methotrexate, medicines we really try to avoid. And they're in red because there are more potential risks and more issues with them. But I put this out, and it's been interesting. I've gotten a lot of feedback from colleagues, mostly positive, some people not liking it. But the idea is that from there, you could sort of use that as your smorgasbord, as your buffet, and take from that to build a very specific plan. And this, to me, is the nicest way to put all this together. We can have a flare-up plan, a rescue plan, something to do if you're in trouble. Potential something a little stronger, but maybe something you don't want to use all the time. Now, it could be a steroid there. That's where I would put a steroid. But if it's non-steroidal, as you saw, I have kind of the stronger agent. So maybe for a patient, that's their topical JAK inhibitor. It's a little bit stronger. You're not supposed to use it all the time. Those have a 8-week limitation of use. Consistently. You can use them long term, but you're supposed to take little breaks after 8 weeks of continuous use. And then a maintenance plan when you're better, something to do to help maintain. Now, again, for somebody more mild, maybe that's just a moisturizer. That's great. No medicine at all. That'd be fantastic. But maybe somebody says, oh, as soon as I stop the stronger medicine, I flare up. So maybe, again, we'd look back at our ladder and we'd say, okay, you can use your topical JAK inhibitor when you're flaring up. And I'm looking at rung number 3 from the bottom. But when you're better, then maybe you'll use your topical calcineurin inhibitor. Maybe it's pimecrolimus or something to those trouble spots. And what I find is that for a lot of patients, we can hit this balance where we're using something a little stronger for a brief bit. And I put up to 1 week. You could change it. Some people like to do it a little longer, but I like to do it a few days up to a week. And then when they're better, something a little safer, or ideally no medicine at all. And doing this has been pretty transformative. I feel like I can get the vast majority of my patients better, but safer for longer, and that's really the goal. Can I get you clear? Can I keep you clear safely? And can you keep it up? And doing all of that has been pretty amazing. Of course, I'm humbled every single day. I meet cases that I truly, truly, truly get stuck on and have to call colleagues, and I refer patients out for hypnosis, for acupuncture, for traditional Chinese medicine therapy, all these different things. And I do work with people at different centers, even in France now. I feel lucky that I got to send a patient of mine to France to get that kind of intensive therapy. I also send patients inpatient to Mayo Clinic, inpatient for pediatrics at National Jewish Hospital in Denver. And we really, really try everything to get patients better. But I hope that's helpful. I won't drone on too much longer. I just wanted to give a little bit of that introduction, and so you can see a little bit of my thinking and kind of where we're at, I think, as a field, or at least where we're hopefully at. I know that there are some people that don't agree with this. And again, I've had some colleagues who don't like it at all. They don't appreciate that at all. But I really do think that for the right patient, what I often tell colleagues who are skeptical is I say, listen, if your patient isn't going to do what you're recommending, what's the point? Like, if you're not willing to help them or bend for them, what are you accomplishing in that visit? If they say, I don't want steroids, and you say, well, it's steroids are the highway, I think we've done everybody loses in that moment. It's a big disservice to everybody. I'll shut up now and I'll open it up for questions.
This is amazing. Thank you. What do you recommend for patients that are having trouble maybe communicating to their doctor? I mean, I know that first, the form that you were showing and how to evaluate your skin would be really helpful. But what if they're also like, if they're just not receptive, for example, like.
Yeah, I mean, I think, you catch more flies with honey than with vinegar. So I think trying to be nice and even just saying, listen, I know you might think I'm a little crazy, but I really prefer to avoid steroids. I'm a little nervous about them. Could you work with me in this way? And I think I think that's a very reasonable thing to say. I would almost never and even if it sounded kind of crazy, whatever the patient said in that way, framing it that way, I would bend over backwards to accommodate them. And if the person really didn't even listen to that, I'd say then it really is a time to find a new person. Being kind, being open, being really, honest and saying, look, I understand everybody agrees with this. Maybe you think I'm a little crazy, but would you work with me in this way? To me, I can't think of anything more powerful than that. So if they don't, it's time to find a new person to help you get through this.
Yeah, I think that's a good point. I wanted to ask you about the phototherapy. I was surprised that was listed as mid-risk. So is it just this like skin cancer type concerns, or what is it?
Very, very safe. Just more because that's that whole efficacy, access, safety, tolerability. I think phototherapy is clunky for a lot of patients. They have to come into an office, so there's definite expense. Even in the US, it's fully covered by most insurance. And in the old days, there was no cost, but now almost all of my patients have to pay a copay every time they get it. So even though it's covered, they still have to pay it could be $20 or it could be $60. So if you're coming 2 to 3 times a week, that becomes extremely expensive in a short period of time. Plus there's a risk of a burn. And you're right, long-term skin cancer risk is there. It is tiny and probably not real until you've gotten like more than 10 years, which almost none of our eczema patients do. It's really more psoriasis patients. So we feel very good about it, but it does have some more risk than a cream. It's definitely more to it than a cream.
And I think you and I had a side conversation. There's really not any good devices you could use at home. I know they're coming out with like photo devices for different conditions, but for eczema, you don't think there's anything good yet that they could use at home.
Right. I mean, we can get a home phototherapy unit, but it's a prescription unit. It comes from the company. It's calibrated, all that kind of stuff. But people often ask about these red lamps, and red LEDs. And I think those are soothing. I think that they have some evidence for wound healing. Like they're cool. I don't think they're dangerous, but they don't really seem to do much for atopic dermatitis. And I have a few patients who've paid a lot of money and had these built into their homes and done all this stuff. And if it feels good, if it's relaxing, great. I just don't think it's like going to necessarily be a therapeutic replacement for anything we've talked about.
Yeah, that makes sense. And then you were talking, the scorecard in the beginning was super interesting. I love that. I think it's really cool. This, I think, is great to bring to your doctor, like you said, when you have an appointment. Journaling is also good, right? To keep track of your symptoms nonstop and as you go. Like, would you recommend that sort of thing, doing it once a week? Or are there like any apps or trackers or anything like that you find are really helpful? Maybe easier. People like apps, so I don't know if there's anything you like.
Yeah, there are a couple. The one that I've been mostly recommending lately is Eczema Wise. So Eczema Wise is actually through the National Eczema Association. It's totally free. The data all stays on your device. It doesn't get shared anywhere. There's no infrastructure for it. It just stays on your device. But you can show me, patients can show me on their screen their number of flare-ups and all these different trackers. There are other ones. There was one called the Eczema Tracker app. I'm not sure if it still exists, but that was a nice one a few years ago as well.
Oh, I didn't know about Eczema Wise. Thank you. I'm going to have to make a list of all these great resources you've given us and send it out in the email follow-up to everyone, because there's a lot of people that couldn't attend that wanted to. So I will do that at the end too. We'll send a replay out. And I did want to mention, I know Winnie has a question here, and if anybody else has questions, please drop them in the chat. I did want to say that Loma Lux has generously offered to give everyone here a free hydrochloric acid spray. It's 2 ounce. So I'm going to, in the follow-up on this, I can drop it here. There's a link, and you just need to provide your address and they'll get those shipped out to you completely free, which is really cool. So let me drop the link here for you so I don't forget. And those will probably ship out this week or next. So very cool. Chance to try that out. Let's see. Okay, so Winnie's question. She was saying, my daughter's eczema cleared up when the weather started warming up last month. Is there anything we should do now, spring and summer, to prepare her skin for the fall, winter?
Yeah, it is very common for people to have more seasonal flare-ups, and most people fit into the pattern of your daughter. The summer is better than the winter, although I do have some where it's the opposite. The heat and humidity makes them go crazy, and they're better when it's cooler. There's probably nothing great. Just enjoy the summer, enjoy the break from things, keep the skin really happy and healthy and moisturized. And then, I think the biggest thing is, as the weather starts to change, just really staying on top of it, because we really think this is a disease of vicious cycles. So if you can prevent prevent it from getting really bad. It's just so much easier to control it and prevent all this stuff, as opposed to once you're really raging and everything's flared up and bloody and annoyed, then the skin is just so difficult to get it to heal. So at the first sign of something, maybe even meeting your doctor like a month or two before it gets cold and saying, can we have a plan and get everything ready so at the first sign we can control it.
I love that. My son Tristan, he's doing great these days. He mostly grew out of it after all the things that we had worked on, and now he's good. He can eat anything now, which is amazing. Like, he was one of the ones that food really like triggered things, but he also suffers really badly in the spring still. That is the only time, and it's from pollen. So it's the pollen direct. So it's like contact dermatitis actually is more of, I think, what it is, I guess. So I don't know how common that is, but that was an interesting one. It took a long time for us to figure out why in the spring is this happening. But he started developing regular allergies as well. And then it was like, it's at the same time, the same connect. So it was interesting. That's a popular one, I guess.
Big time. Yeah, absolutely.
So Terry is asking if someone is in TSW, are the ladder treatments the same? She's in my daughter is in London now and starting Dpixion after being on Cyclosporin.
The Cyclosporin, yeah.
Thank you.
Yeah, the first question about TSW, yes, I would say I put that thing together sort of with TSW in mind. That's sort of what was the inspiration to write this therapeutic ladder. Some of my TSW patients will not use certain medicines. Some of them don't want to use the JAK inhibitor. Some of them don't want to use tacrolimus or pimecrolimus because they feel that they're kind of similar to steroids. My jury's out. I'm not sure. I mean, I really do feel like steroids are pretty different, but I respect patients. So if they say, I don't want to use this class, I'm not going to use it. But yes, I do think it's a rough framework for how to think about it. And it can be helpful for sort of navigating, but I really do think of it also for patients who don't even want to start down that route or want to minimize their steroid. For the second point about the dupilumab after being on cyclosporin, that's great. I mean, because in many parts of the world, there's a step requirement, meaning patients before they can get dupilumab, which is still a branded medicine, it's still very expensive in most parts of the world, they have to go on an older medicine first. So like cyclosporin or methotrexate. We're lucky in the States, we generally do not have to do that. We pushed back really hard. In the beginning we did, and we pushed back very hard and said, you know what, this is not right because cyclosporin has a ton of side effects. It's far more dangerous than even the newest, the JAK inhibitors by mouth. They're very dangerous. The cyclosporin can damage your kidneys. It increases the risk of cancer. It increases all sorts of stuff, risk of infection. So we really don't like patients on that. But many patients, if they've tried it in good faith, you can say, listen, this is not a long-term thing. And then we can switch them to dupilumab, which is, again, not perfect. It's not a perfect drug. I wish it were, but it's a good one. And it's the one that, I really try to get patients on who need a systemic agent first.
It's so interesting. The medications that you were listing, I've never heard of a lot of them because when we were doing this with my son like 12 years ago, there was like steroids, oral or topical steroids, and there were a couple other things, but those were like the big ones. And all these seem to be relatively new over the past 10 years, I guess, some of them.
There are some new ones. I mean, the truth is cyclosporin is an old medicine. It's been around since the 60s and 70s, but a lot of dermatologists don't use it. They don't necessarily, I don't want to say they don't know how to use it. I don't mean to be impolite, but they just don't mess with it. It's a powerful one. And, it's definitely something that is usually reserved for pretty severe cases. So sometimes they won't even bring it up.
Yeah. And Dpixion was, in the past 10 years is new on the scene. So how is that going? Like now that we've had people on that I remember it's like biologics that sounded really like frightening as a parent, but a lot of people have been on it for a long time now. So what are you seeing like the long-term effects?
Thank goodness. It's been pretty darn good. Again, not perfect. Anybody says anything's perfect and no side effects doesn't know what they're talking about. But no, it really has been pretty good overall, pretty good safety, really good efficacy, even prolonged efficacy. I have some patients who've been on it. It launched in the United States in March of 2017. And I have a whole bunch of patients who've been on it since then. And I also have a bunch of patients who've been able to come off, as I say, and they're off of it and doing great. So that's really neat. And now it's approved down to 6-month-old babies. So I even have some little itty bitties on it. And it's been great because it protects them. I think it prevents them from a lifetime of just tons of steroid overuse and abuse and, that up and down terrible cycling, which we know affects growth and development, all this kind of stuff. So I'm seeing happy, healthy, growing, thriving babies, who literally a month before were absolutely miserable and falling off the growth curve. And that's been dramatic, really, really dramatic.
Falling off the growth curve is quite scary with some eczema. My goodness. Let's see, we have a question here. I would like to know if, oh boy, cheilitis on the lips is considered eczema on the lips, and is it okay to use Absolura on the lips? My dermatologist has advised me to use it on the lips, and it works, but when I stop using it, there's a small rebound until it goes into remission again.
Yeah, cheilitis or inflammation of the lips can be part of eczema. It can happen for a number of other reasons too. But yeah, you probably can use Opsilor a little bit there. It's not my preferred. The vehicle is a little bit too lightweight, I think, so it can be actually drying. It does contain propylene glycol, which can be an irritant. So it's not my first choice, honestly. In the pattern you're describing is a pattern that always sends a little red light for me when I hear like it's flaring right up, it's doing this. That tells me we're not in the right path. So I would definitely reach out and say, this helps me a bit when I use it, but I don't want to use it all the time. And as soon as I stop, it seems like it's irritating me. Can we switch? And there are a lot of different approaches. I mean, definitely you can even look at the ladder and pick some other things that might be better there.
That's exactly what happened to my son with topical steroids. So it's interesting to hear you say that wouldn't have been your approach. Let's see. Laura is saying, our worry about steroids is suppressing the eczema and it comes out as asthma, a common belief in the holistic world. What are your thoughts on this? We are really struggling to keep my son's 3-year-old flare-ups under control. He has situational asthma when he gets sick. Steroids worked well for him in the past, but we've avoided them for about 1.5 years now, in part because of this fear.
Yeah, I don't think it's a crazy fear. I mean, I think there really is something to this. The good news is it's extremely, extremely rare. I have not seen this happen very much, but I have had a couple patients where it really seemed like we kind of pushed the inflammation from their skin into their lungs. It's pretty crazy, but typically does not happen, thankfully, because really part of what the steroids are doing when we're treating the skin is they really are cooling down the inflammation. They're not, I kind of conveyed that image of pushing it in, but typically they're more just calming those cells down and making them stop, send out those inflammatory signals. So I think, again, if you can use them safely and in good, little bursts and they help and you're not reliant on them all the time, it could still be reasonable. But if you're concerned, I think that's reasonable too. And you could take a different approach. Another approach would be, I don't know how old your son is, but phototherapy, the light therapy is a different approach that really does, again, cool the immune system down in a different way. And of course, things like the dupilumab. 3. Okay, so phototherapy is probably not possible. Usually 6 and up is where we can do that. So for 3, maybe if you'd be comfortable with some non-steroidal treatments, that could be tried. If it's bad enough, one cool thing about the dupilumab, not to keep pushing that, but that actually is approved for asthma as well. So for patients that have both, it really can help for both of those things at once, which is nice. But I do think, it bears you talking a little bit, talking to maybe the allergist who's working on the asthma and talking to the dermatologist, say, what's the right approach here? How do we really stay on top of it? And part of it is, taking a small leap of faith and saying, okay, maybe we'll try it. And if we feel like the asthma flares up, then saying, okay, this definitely didn't work the way we hoped. So we're not going to go that route. And I feel okay with that. At least, we said we've done our best try.
What about like the whole, we know that there's the triad, right, with asthma and allergies and eczema, and that they all kind of go together. Is it because the inflammation is overloaded and it's just this body is expressing itself in these ways? So it's kind of like a given that these three things might happen at the same time? Or
yeah, I mean, you're right. So they all run together, but it's very hard to predict. So most patients only have 1 or 2, right? The vast majority either has, eczema plus one of those things. Some patients, a pretty small minority, has all 3. They have eczema, food allergy, and then typically asthma. And some of them even have 4, like allergic rhinitis as well. Mm-hmm. So we see these different patterns out there, but it's hard to know. One thing I will say we do know, and I feel very confident about this now, and increasingly so, everything continues to kind of go this direction, is that we used to kind of talk about this idea of like, well, we got to be careful of foods because the foods are driving the eczema. We got to be so careful. But we realized we were doing it wrong, right? We actually created this whole epidemic of peanut allergy and probably other food allergies by telling people to avoid these foods. It turns out it seems to be the other way around for the vast majority of situations, that the broken skin, the inflamed, damaged skin barrier allows for food proteins to get into the body in this abnormal way and cause allergy. So when I meet families who are kind of nervous, like, oh, we don't want to treat, we're really afraid. I'm like, I agree. I wish we didn't have to. I wish this kid didn't have eczema at all. But if we let it keep raging, I'm worried we're going to develop these other allergies. And in fact, there was a really interesting study that came out just a year or 2 ago called the Pachi study that was able to demonstrate aggressive treatment of atopic dermatitis decreased food allergy risk. So this really seems to be
Wow.
a thing. So, and when I say that, a lot of families are like, okay, crap, you're right. Let's do something, because we don't want these other allergies or allergic diseases to come up. And again, I can't promise this. I don't know for sure, but to the best of our knowledge in 2024, this seems to be a real thing. Not to mention the fact that letting kids suffer, I think, is really hard on them. And I think really measurably has effects on their development and their growth. So,
Emotionally.
it's a win-win, I think, to get good care. It's like, last little anecdote, but this resonated with me. I had a mom who was, again, pretty nervous about anything. She's like, we want to be natural. We don't want to use any treatments, but they had done a lot of stuff and the kid was still really miserable. And I was like, you've done such a great job. You've tried all these things. You've changed diet. They've moved, they got rid of the dog, all this kind of stuff. And the kid was still pretty bad. And she goes, well, can you just rank the danger of the treatments you've recommended? And I sat there for a minute and I said, okay. But then it dawned on me, I put number one, I'm like, letting this eczema continue to be this severe untreated. And that's when she kind of came around. She's like, I think you're right. Okay. Because I was like, there's a 100% chance your kid is miserable with atopic dermatitis because that's why you're here. Like, that's actually happening. Everything else is in the sky. It's possible. Bad stuff can happen. I mean, God forbid, you could be going to the grocery store and God forbid you could get hit by a bus. I mean, it can really happen, but you can't say I'm not going out. I mean, some people can, but we'd call that person, we'd say you have a problem. You have to take some risks. The world is just full of risks. There's danger everywhere. Weird stuff can happen. And putting it in perspective is really hard, in part because a lot of times we don't know. What is the risk of TSW? I don't know. I think it's actually pretty low across the universe if we really think about it, because I meet all these patients every day who abuse the heck out of steroids and somehow they seem to be bulletproof. They don't have it. And then I also get a lot of referrals of patients who have full blown TSW and are miserable. Sometimes they're beating themselves up over it. And I'm asking them and they really didn't even abuse it. So I'm like, gosh, I don't even know if we can go back in time. I don't think you did anything wrong. Like, they blamed themselves. I'm like, I think something about you was unlucky. Something about your skin or your immune system just didn't like this. I don't know if we could predict it yet. So I don't want people to dwell in the past. I want to think about going forward and how can we help them get through this next point. I mean, that's my job. And I never push it on people. Some people say, no, thank you. And that's fine. But I really want to offer that if they're ready.
But you're right. It's seeing your child suffer like that. It's awful. I remember it's tough. So Lauren was asking or saying, I was taking Dpixion for 5 years and seemed to stop working. I am now taking Rinvoq, but still get constant flares all over my body, sometimes very severely. Do you see any issues continuing Rinvoq, as it seems to not clear my skin? It does maintain the itch, however.
Yeah, I mean, you're my kind of patient. That's like my number one type of referral is exactly your story. So that's what I see all day. And it's really tough, right? So I think we have to, we'd have to go through that East or a star plan and say, okay, how much better are you? Do we think it's worth it? Now, the good thing is, I don't want you on the Rinvoq forever. I don't want anybody on it forever because it is pretty strong and it does have some risks in the longer term, unless they have to. There are some people that have ulcerative colitis or they have arthritis. There are things, or even bad eczema, where nothing else works. But the good thing is there's some new things coming. There actually are 2 new biologics coming down the pike very soon. I think in the next 3 to 6 months, we're going to have them. So what I've been telling my patients, again, I don't know your case, and please do not take this as medical advice. It's not. It's just the way I'm thinking about it for some of my patients who are having some improvement on Rinvoq, but don't want to be on forever, is I'm telling them, maybe we could stay on this for a few more months. We'll watch you closely. And then when we have these new options, we can try these new options and see if we can rotate off. And I think that's, the best we can do for some people, because again, do I want patients on these medicines? No, but if the alternative is prednisone, that's terrible. I think prednisone is probably on the order of, and I'm not exaggerating, 10 times more dangerous in a number of the metrics, like blood clot, infection, malignancy. I mean, you can look at some of these numbers and it can be like an order of magnitude more dangerous. And even though many clinicians are like, oh, come on, a little steroids, it's fine. I'm like, you're nervous about the Rinvoq, but you're giving out the prednisone. Like, I think you have a confusion. I always joke and I say, it's like the person who says, I never fly in planes. They're dangerous, these aircraft. And they get on their motorcycle without a helmet and they ride away. And you're like, I think you don't understand risk very well.
Oh my goodness, that's a good point. Terry says, does Dpixion kick in pretty quickly? She's in a horrible flare and abruptly had to stop the Cyclosporin. Doctor wants her on oral steroids for a bit to bridge. He said topical steroids are different than the oral ones and how it affects the skin and TSW.
Yeah, yeah. I mean, I would say yes. The one time I will use oral steroids is in a situation like that as a bridge. I think that is not unreasonable. Dupixent usually takes a couple of months to kick in. I would say no longer than 3 or 4 months. If it's not doing anything in 3 or 4 months, there's a very good chance it's not going to work for you at all. You could stick with it a little longer, but I think it's usually not the right call. And some people are lucky, even after a dose or two, like the first couple of weeks, they see some improvement. So I'm hoping you're going to be in that group really quick, see some improvement, and maybe you won't even need the prednisone bridge. But if you do, I think it's again, not specific medical advice. I'm just giving general thoughts. My general approach to patients in that kind of a situation will be, yes, this is reasonable because we have an exit strategy. You know, I don't like to just give somebody prednisone without any strategy, but you have a very clear path in that setup where you're transitioning.
Another question, what might you recommend to calm the storm of itchiness? I guess this might be non-medical, and then also, or I said non-medicinal, and then also maybe medicinal.
Yeah, I mean, it's always a key question. What can we do? You know, I'll tell you one of my favorite sort of home remedies that I love, and it's based on a paper that came out of Germany a couple of years ago, is you go in the kitchen, you get some black tea, just plain old black tea, no flavoring, nothing fancy, just plain old black tea, and you brew up a big bowl of it in hot water, and you can either drink that or you can pitch it, then use the same bag and brew up a second one. So it's kind of the weaker second steeping. Now you take that bowl of tea and you put it in the refrigerator, let it get nice and cold. When it's nice and cool, then throughout the day, you take a washcloth, you dunk it in, and you do a compress. And I'll put the little link on my website to this.
Yeah, I'll get all those links from you then. This sounds super interesting. Okay.
And it is really powerful. It is one of the most powerful things I've ever used. It sounds so dumb, but people are like, why did this work so well? And we don't really know, you know, it's botanical. So it has lots of good aspects, but very, very safe, very, very gentle. I put the link in the chat as well. So
never heard anything about black tea. I've heard green tea, good things about green tea. So have you tried that? Do you know if that works as well? Or
there was a paper years ago that talked about that. There's also some literature that says drinking. So this is a kind of topical version, but drinking oolong tea may also help after meal. And then what else can we do? Yeah, cool compresses like this. One of my favorite over-the-counter products, I have a couple. I'll put the links in. One of them is called Dermaleave. I don't know if you've heard of this one. This is an anti-itch cream. It's non-steroidal or anything like that. It's very gentle. It is a little pricey, I will say, but it works by kind of soothing the nerve endings, which is kind of cool. So it can be a nice little treatment for a number of my very itchy patients. And then the other one is a newer product, and I got to be part of a trial with it. It's by a Cetaphil company, and it's an anti-itch gel that is really nice. It comes with, I'm punching it in right now. What's so cool is that it actually has like this roller. So it's like a cooling metal roller, almost like a big ballpoint pen, and it rolls across your skin. Again, non-medicated, just cooling and soothing. I put that in there. It's an American link, and I apologize. Both of these are. I know a lot of you might be in Canada, but I think you can get it worldwide.
That's interesting. So cold in general is a really good remedy, I think, for itching. So just even an ice pack, right? If they have nothing else, just some ice wrapped up in a towel, and yeah.
Absolutely. And then one last little thing is what's called habit reversal therapy. I'm going to send you a link on our website. And this is like some replacement behaviors for scratching, because we know telling people stop scratching, that doesn't do anything. But this is an approach that really has been validated. It's been studied. And I have a little guidebook. It's just 2 pages. It's real quick. It's easy. But you basically replace scratching with some other behavior. It can be tapping your fingers. It can be gently rubbing the skin. It could be playing with worry beads. It sounds so dumb, but it really works. There's honestly evidence that it helps. So it's something simple, but I think it also protects you, even if it's just a little. If it helps a little bit, it's just that much less that you're ripping at your skin, scratching at it.
So I didn't know there was a name for that, but we did that with Tristan. So we would tickle his skin. So it was like tickling instead of scratching. And we'd always remember, tickle, don't scratch.
That's it. And it sort of sounds obvious. Yeah.
Oh, that's very cool. Well, we're about to wrap up. Wait, I see somebody else had something in here that I missed. Oh my goodness. I think it was this one. Grace asked, my 7-year-old is currently seeing an acupuncturist who specializes in pediatric dermatology, as eczema on his lower legs has not subsided after months of use with topical steroids. We are seeing a pediatric dermatologist next week, and the acupuncturist suggested requesting a macrolide. Where does this fall on the ladder?
Yeah, typically macrolide really means an antibiotic. I'm not sure if that's what they mean. So like erythromycin and azithromycin are kind of in that family of macrolide antibiotics. It turns out that protopic and elidil, tacrolimus and pimecrolimus, are cousins of this. Maybe that's what they meant, but it's not quite the right term. So I'm not sure what they meant. Typically, we don't just put people on antibiotics unless they're infected. It doesn't seem to do that much. Some people do improve, but it's not good stewardship. So I'm not sure what they meant. You might ask them again and see, or you could tell your dermatologist, or if they wrote something down, and then you could maybe even have them talk and say, can you contact each other? But yeah, typically I'm not sure what they mean, unless they're referring to the fact that tacrolimus and pimecrolimus are kind of distant cousins of that.
And it looks like we have time. One more question here before we have to wrap up from Anne. My daughter has developed, maybe another one with group time. My daughter has developed eczema on her face and scratches off her eyebrows. Any recommendations for the face?
Yeah, I think some of the same things we talked about. So habit reversal therapy would be great for scratching on the face. The cool black tea compresses would be fantastic. And then either of those two gels would be fantastic too. They're really good anti-itch. Of course, in general, we also want to treat the inflammation. So the therapeutic ladder would be great. You could maybe you could print it out, bring it in and say, can we use some non-steroidal stuff to get these eyebrows better? Are there any things that you like on this? That would be fantastic.
Are you able to drop those links here, or I'll get them from you afterwards to your slide or the slides and everything? Or do you have anything online?
I don't. I just thought you were going to share the recording. Can you share the recording?
Yes,
And that'll have everything.
Okay, that'll be good. We'll just do that then. Jorge, he left. He had a question, but I think we're good there. So yeah, so I think we're about time here. So Dr. Leo, this has been so helpful. Thank you so much. So happy that you could join us. Thank you very much.
My pleasure.
Thank you very much. Thank you. Thank you.
Yeah, everybody come off mute and say thank you to Dr. Leo.
Thank you so much.
Appreciate it. So
Thank you.
Thank you guys. Have a great week.
Thank you. You too. Take care.
Bye.
Bye.
Bye. Wish you could have seen him before you left Chicago.
Oh, you told me you acupuncture.
No, that's one thing. How do I get myself off of this? Do I just
Like
click?
acupuncture isn't going to cure my
I don't know what you're
skin.
trying to do. End the call. Hang up.
Oh, yeah.